Ankylosing, flail joint, we'll deal with those when we get to ortho. AC joint, so let's get it on the other end. Acromioclavicular joint, AC joint, right in through here. So, broader, flatter end of the clavicle. So if you had your hands on it, you'd see that it's a little bit squishier, not squishier, but thin in the end. You have your acromioclavicular ligament sitting down there at the end, kind of encapsulating the end of the bones. But the primary base of support is really coming from the corticoclavicular ligament right there, which is the conoid trapezoid part that tethers the end down. If those get damaged, then you'll see the clavicle kind of pop up looking like a piano key. You can push it down, it just springs back up like a piano key does. Funny how the special test that is called the piano key sign. Underneath that, we've got the coracoacromial ligament. What does that support? What do you think that supports? What landmarks does it go from?
Coracoid.
Coracoid process.
The acromion process.
So the acromion process. So this not being the skeletal program, I don't really have the ability to select individual components. But acromion process is this section that comes right through here as it flattens out. You can feel that on your shoulder as it comes up from the back. The spine of the scapula progresses laterally into this nice big broad fat connection. The coracoid process is on the anterior surface. And it's a finger-like projection that comes forward. Both of those are coming off of the scapula itself. So this ligament right here, this coracoacromial ligament, is stabilizing one piece of bone to the same piece of bone. Now most of the time that we have ligaments, it's going from one bone to another bone. Across an articulation. So what you've got is, this is actually deepening the glenohumeral socket to help stabilize the humeral head in its joint, in its location. Which in its own right is going to cause us some unique components as well. All right, what other kind of funness do we have? Coracoid process into the humerus on the inferior side, anterior inferior side, is the coracohumeral ligament, which helps prevent anterior displacement of the humeral head. Then we have the joint and the capsular ligament, which is the glenohumeral ligament. And let me pull up. On that component, we've got the superior, middle, and inferior components. So those glenohumeral ligaments are really just thickenings of the joint capsule itself. So they're not so much of unique, identifiable pieces, so much as just thickenings within the joint capsule that help stabilize. Anterior shoulder dislocations are going to stretch the middle and the inferior, because as it pops forward and down, it's going to stretch out that joint capsule. So let's talk scapula for a minute. Scapula does not have any, it has one connection to the axial skeleton, and that's through the acromioclavicular joint. So we don't really talk about the scapulothoracic joint as so much as the scapulothoracic articulation, because we've got this massive bone that glides, it floats on top of the rib cage. There's nothing in here that connects it by ligamentous vein. It's all entirely developed, its stability is developed by muscular activation, muscular strength. And the strength of that stability here implicitly controls the ability of the humerus to function with strength and power and control. So, is this one have motions? Pitchers. Pitch a baseball, 106 miles an hour. That's kind of fast. All of that motion is generating movement of the humerus transferring out to the end range of throwing the ball on the stability of the scapulothoracic articulation. So the strength by which those muscles can stabilize your scapula dictates how much stability. So as frequently as we spoke about how core and glute med stabilize hip and lower extremity components, your scapula becomes that intrinsic connection piece of motion in the arm to the exoskeleton. Off of this, there are considerable numbers of muscles throughout. So what we've had so far, sternoclavicular joint, acromioclavicular joint, neither one of those have any direct muscles controlling their motion. Scapulothoracic articulation, glenohumeral joint, and in the glenohumeral joint we have what motions? So where we can hear abduction, adduction, rotation. Now hold on, rotation, circumduction is here. So what is rotation? No, that's going to be still, circumduction is still going to be in through here. Rotation, well, okay. Usually we think about it more in terms of intraocular rotation here, which would be this as well.
What are you doing? What are you doing?
So circumduction is more of the circular motion here. Rotation is think of more as internal external rotation, which would also be that. We can get there. So what else is with the what else is with the glenohumeral?
Flexion extension.
Flexion extension. So forward flexion, extension, abduction, adduction. Internal external rotation, circumduction. So there's a lot going on there. Now, if we go back and look at this guy here, the scapula isn't set on the cage because the cage is curved and it comes around. So it's not actually set either in a horizontal or a vertical alignment. It's actually a 45-degree turn in that plane there. So we start talking about something called scaption. And scaption is referencing the movement of the humerus within the plane of the scapula. So if this is abduction, my scapula is tilted about 45 degrees from that. This is forward flexion. Again, my scapula is still aiming off this direction. So scaption is referencing my arm at 45 degrees, in between flexion and abduction. So it's that middle range here, which is the loosest packed position. We start talking about joint positioning. If you put it in a plane of the scapula, that's the most relaxed the joint is going to be, is within that plane of the scapula. Now what are we going to have for motions of the scapula in regards to the thoracic cage? Retraction, protraction, retraction. Elevation, depression, and then you'll get some tipping and tilting. It'll tip forward. Pectoralis minor originates off of, well, inserts into the coracoid process. So when it fires, it's actually going to tip and help do this motion, pulling it forward, tipping it forward. So what do we have now? We have a whole series of muscles that are going to act on the humerus to cause that glenohumeral motion. The first major sets are the ones that you tend to have guys working out, people working out in weight rooms. The ones that look good, right? As is always the case. So we go and take those. What muscle group is this? Deltoids. We can hide that group out of the way to see underneath. From there we have biceps brachii. Biceps means two heads, so there's a long and a short. We can pull those out of the way. The antagonist of the biceps is what?
Tricep.
What is your deal?
No.
Look out, here's the triceps. We can pull those off. And you can see how that makes up most of the muscles that surround your humerus. What muscle group is this?
Pectoralis major.
Pec major. I can hide it. I'm hiding underneath
Oh.
in the shadows.
Where'd it go?
It's like we're in
It got faded. Right in here is pec minor.
Hate it.
So now we have this group sitting right in here.